Good morning. Welcome to today's session. It's a great pleasure to have so many of you in this room on Monday morning early on our session, Improving Maternal and Child Health Through Data-Driven Segmentation. Let us introduce ourselves as the host of this session. My name is Melanie Wendland. I'm the co-founder of Sonder Collective, a global network of designers, researchers, and innovators working together with global health organizations on complex missions requiring creative and multidisciplinary approaches. And with me is Tracy Johnson.
Good morning, everybody. And echoing Melanie, thank you for joining us at this early hour. I am Tracy Johnson. I'm a senior officer and design anthropologist at the Bill and Melinda Gates Gender Equality Division. I lead much of our work on vulnerable populations, as well as the Pathways Initiative, which we'll be talking with you about today.
Thank you. Before we start, we have a round set up this morning, and we have screens in 3 corners of the room. If you, however, have troubles looking at the screen, you can also follow the presentation on your phone by scanning the QR code. Now, let us dive into our session this morning with an immersion by Tracy. Over to you.
Great. So I'm going to provide a little bit of context for what we're going to hear and talk about today. Taking responsibility for health in a fragmented world has really never been as urgent as it is today. We face increasingly complex problems in the field of global health. These are often compounded in ways that we don't fully understand by the social determinants of health that contribute to poor health outcomes. In our attempt to better understand this complexity, it's possible that we as a field have contributed to this sense of fragmentation. We often cut the global health community into our health verticals. And so we approach problems under 5 mortality, maternal mortality, whether a woman goes to ANC, and so on. The result is that we've become focused on solving a single piece of the puzzle at a time. Now, don't get me wrong, we have also made great strides with this approach. For example, cutting child deaths from diarrhea by 90% since the 1990s. But at the same time, over the past few decades, some indicators have been stagnating, despite our efforts in improving delivery of care and developing new technologies. Add to these challenges the fact that we are living in a world that faces shrinking resources for global health. So the question becomes, how are we to face those remaining intractable problems? Can it be that looking at health through primarily a biomedical lens has led us to where we're not always asking the right questions? That the lens of vertical health programming has led us to designing micro innovations that solve for single problems? What if we realize that what we need now are macro innovations, ways to see the big picture, the whole of a woman's life, the complete puzzle, and from there, make bold moves? Pathways is the name of the initiative that we will be talking with you about this morning. And we like to say that it's a novel approach in that it is design-driven. And it also relies on segmentation to make narrowing the gap between the social determinants of health and health outcomes possible. The WHO estimates that the social determinants of health, those non-medical factors that include the environment, someone's occupation, their level of education, culture, social structure, and more, shape the conditions of daily life that account for up to half of the illnesses and half of the premature death worldwide. With Pathways, we've developed a rigorous mixed methods, quantitative and qualitative approach to identifying, measuring, and operationalizing the social determinants of health through the lens of vulnerability. Since 2019, Pathways has been used by governments, implementers, donors, academic organizations, some of whom you're going to hear from this morning, to inform strategies and design solutions more holistically. There are 4 ways that we like to talk about pathways making a different impact. First, it enables us to really consider those upstream social conditions and the inequities that drive health outcomes by moving beyond a clinical care only focus. It also, secondly, enables us to provide differentiated services that identify and prioritize the need of vulnerable populations. Third, it offers a holistic set of women-centered services that promote health, but also well-being. And then finally, we think Pathways has the potential to integrate health programs with social and community systems to enhance impact. Pathways is deeply embedded in the quantitative rigor that our field expects. And yet it also brings what we've been missing, a bigger picture of people, their interconnected needs, and their emergent potential. Ultimately, taking responsibility for health in a fragmented world means putting the pieces back together and focusing on who is at the center of care, a woman, a child. As the president of as the division I sit on, Anita Zaidi, has said, Pathways is a bold innovation because we know women are more than just one indicator and that health is always more than just one number. I'm going to turn it back over to Melanie, and we're going to start to meet some of the women from Pathways.
Thank you, Tracy, for setting us up. And now it's over to you. Over the next 6 minutes, we're going to listen to 2 women from Kano State, Nigeria. Their stories invite us to connect with the lived experience behind the maternal and child health topics that we all care about. As you listen, take the card that's on your seat and see if you can map some of the factors that appear in the story on your leaflet. This helps us to listen more actively to what we're hearing, but don't worry, we will not evaluate your cards. Okay, we can start with the first story.
My name is Asana. I live in Warawa, a rural community here in Kano, Nigeria. At 14 years old, I was married to a man my parents chose for me. He was almost 2 times my age and he already had wives and children. I cried a lot because I was far from my parents' home. In fact, at first, I did not even talk to him. The other wives were kind, but they were distant. When I was growing up, I was one of 18 children. I remember vividly. There was so much work to do in the house. My mother and my aunties always taught us, the girls, how to cook, how to clean, and how to behave. I think around 12 years old, I got my first period. I didn't even know what that was. My mother quietly explained what to do, and she warned me, never let a man say this. Around 16 years old, I had my first baby. Soon after that, I was pregnant again. I lost the baby. She was just 3 months old. She was very small and very weak. It was just one morning we woke up, I found her still and cold. Oh, it was a difficult time. I felt so alone. But now I'm 32 years old, alhamdulillah. Our home is filled with children. We often struggle for food, to pay for school fees, and we don't even always have money for medicine. I also try to help by knitting caps, but sometimes it's not enough. In our own house, we don't go out without his permission, not even to the hospital. That's how we do things here. My 7th child died at birth due to complications. It's just how God willed it to be. Giving birth at home is a sign of strength. My husband is also kind, but at times when I don't do what he wants, he gets angry, and I've been taught it is his right. I go to the doctor, but here we don't believe in family planning because children are a blessing from Allah, and my husband wants a big family too. I wish I could visit my family more, and make new friends, but I know my place is here, taking care of our own.
And let's hear another story.
My name is Balkis. I live in a large compound with my 3 children, co-wives, my husband, and his extended family. Growing up, I was one of 8 children. My father married only my mother. He worked hard to provide for us. My mother would say, book knowledge is good, but the most important thing is you must know how to run a home. I was taught to be a good wife and mother. I had to cook, clean, and care for my younger siblings. But my father allowed me to finish secondary school, unlike many girls I knew. I got married at 18. It was arranged. He was 38 and already had 2 wives. He was kind to us. I moved into his family's compound. At first, I did not like it. My co-wives were older than me. I felt alone. My husband travels often. He sends money and tells us how we should spend it. My closest confidant is my brother-in-law's wife. Her advice has helped me a lot. Even before marriage, I knew I didn't want many children. I saw how hard it was for women with 10 or more, but I kept those thoughts to myself. When I had my first child, I was excited, but also anxious. I went to the doctor and gave birth at the hospital. The nurses were kind and helpful. After, I wanted to wait before getting pregnant again. I brought it up with my husband, but he refused. I didn't push because my co-wives also don't like family planning. Now I'm 24. My last pregnancy was difficult. The doctor said I must wait, and I'm more determined. I attend community events. That's where I hear women discuss family planning. Some praise it, others not. I have spoken with my sister-in-law and some friends who are using it. I want to use their story to discuss it with my husband. I'm gathering courage to raise it again, and I'm hoping that he will listen this time.
Thank you for listening. 2 women from similar communities, 2 hours apart. When we listened to their stories, some parts of their lives sounded similar. Both started working early to support their families, and both live in similar marital situations. Yet, their stories are not the same. Hassana experiences the loss of 2 children, yet she prefers to give birth at home, while Balkis prefers to deliver at the facility and thinks about spacing. It may seem obvious to us that these differences observed in their stories connect to their health, but understanding exactly how and why they do is not that straightforward. So how can we move from listening to individual stories to understanding whole populations? That's where data-driven segmentation comes in. As Tracy mentioned earlier, the social determinants of health are not new to us. But despite decades of awareness, programs still struggle to address them, to design in ways that truly tackle the root causes that limit access to care or prevent healthy behaviors. From the stories we just heard, it's clear that the factors shaping health are complex and deeply interconnected. Yet, within the health system, we don't have the time and resources and ways to see this complexity. We don't see who is affected by what combination of factors or for what reasons. So we often shied away from this complexity, choosing instead to focus on one problem, one outcome at a time. But that approach leaves crucial questions unanswered. Who are we missing? And why are we missing them? With Pathways, we've developed a scalable method to capture vulnerability and risk in a woman-centered way. It allows us to see more holistically how social determinants and health inequity manifest within households and how households differ across a population. We began by engaging directly with women in communities such as Hassana and Balkis, listening to them, describing in their own words how vulnerability shows up in their daily lives and household contexts. We organized what we heard into 6 broad domains, starting with the woman and her past experience, household relationships, economics and living conditions, health mental models, social support, human and natural systems. Then, using segmentation methods, we analyzed data that captured all of these measurable factors and health outcomes across a community. This allowed us to identify which factors are most strongly linked to poor health outcomes, and not just one outcome, but across reproductive, maternal, child health, and nutrition. Finally, we clustered households based on the characteristics that contribute to poor health. The result is a comprehensive tool that reveals how vulnerability is distributed across a population, from the least vulnerable to the most vulnerable, and what drives those differences. Let me show you what a segmentation looks like in northern Nigeria. In northern Nigeria, we collected data through a population representative household survey done in Pathways. For other geographies, we have used existing DHS data to conduct similar analysis. In northern Nigeria, the sample data shows us a split of households into rural and urban by 68 to 32%. Nothing new to us. Now, 8% of the total sample, which is 25% of the urban population, shows the best health outcomes across the reproductive, maternal, child health, and nutrition spectrum. 27% across urban and rural have slightly worse health outcomes. Close to half of the entire sample experiences poor health outcomes across RMNCH plus N. And 23% of the sample has the poorest health outcomes across the whole health and behavior spectrum. Now, our segmentation algorithm divided these groups by distinct vulnerability characteristics and identified 8 different segments in Nigeria. 4 rural segments on the left and 4 urban segments on the right. We have given these segments names by their geographic orientation and the number representing their risk to poor health. 4 is most vulnerable, and 1 is our least vulnerable segment. As we can see, we have only 1 least vulnerable segment in northern Nigeria. It is interesting to point out that there are 2 more vulnerable households, the purple ones, who share similar poor health outcomes, but actually do have different driving characteristics of these health outcomes. So let's take a closer look. On this table, you can see the household segments lined up vertically. Horizontally, you can see some of the health outcome data we have in the segmentation. Under 5 mortality rate, highlighted in our red column here, is vastly different between the least vulnerable and the most vulnerable. Also, the prevalence of home birth varies, although the 3 more vulnerable segments on the bottom share similar rates. Our analysis has shown that segment membership alone is close to 80% predictive of whether the household experiences a home birth. This means if we know to which segment a woman belongs, we can determine her likelihood of giving birth at home. Let's look at the vulnerability factors. We see differences between early sexual debut, though again, our more vulnerable segments are quite similar in this regard. However, when we look at whether the woman is working, we actually start seeing some differences in the more vulnerable segments as well as the extent to which they experience barriers to seek and access care. There are many more such factors available in the data to help us understand these complex health journeys. The stories today remind us that women's lives can't be reduced to one single data point. By combining what we hear from women with what we measure in segmentation, we begin to understand how social, economic, and personal factors weave together to create risk and also opportunity to intervene differently. In the case of Hasana and Balkis, you may have noticed where they fall within the segmentation. Balkis belongs to a less vulnerable group, while Hasana is among the most vulnerable. Yet, the health system would likely try to reach them in the same way. Diving into the data, we begin to understand that we need to look more horizontally at health and how factors combine to create risk to poor health. The geographic map helps us to see the distribution of segments and how vulnerability manifests across regions, highlighting that interventions may reach different portions of populations in different geographies. As we see on this map, different states have different segment distribution, calling for interventions to be sensitive to these differences. As we move now to our panel discussion, you may have questions around how is this data being used and how has it actually made a difference. We are very lucky to have a group of country representatives here who will share more about their experiencing using pathways as an approach to develop their own segmentation solution in their country, as a way to use data and insights to better target their interventions, and using processes and tools that support more women-centered solution. And with that, I'm going to ask Tracy back on stage to introduce our panel. Thank you.
Thanks, Melanie. If we can go to the next slide. Just quickly, this is a visualization of the countries for which we have what we call pathways segmentation solutions. On the right-hand side, you'll see a non-exhaustive list of all of the different projects that have started to integrate pathways into their work. In a minute, I will invite two people up on stage. One person will join us via video to talk about their experiences of integrating segmentation into the work that they do. On the next slide, these are what we call our 4 use cases. We believe Pathways helps you forecast a more precise estimate of the impact that you might have through an intervention, because you have a much stronger sense not only who the intervention will reach, but who it actually really needs to reach. That has an impact on our second use case, which is resourcing. If you're not saying you're going to reach an entire population, but you're reaching certain segments, you can spend your resources more wisely, more effectively. Of course, we've talked about pathways being design-led. A third use case is how we design in a women-centered way, or we really start with the women, their challenges, their needs, their potential. And then finally, Pathways acts as a baseline of vulnerability. So it enables you to evaluate the work that you are doing in country. So I'm now going to introduce my colleagues to join me up here on stage. First, I'd like to introduce Dr. Amadou Doucouré. Come on up. Dr. Doucouré is a public health physician specializing in health economics. He is certified in health systems research, sexual health and rights, and health systems management in developing countries. In 2017, he was the recipient of the U.S. Department of State's International Visitor Leadership Program in Public Health. He has over 24 years of experience in the design, planning, and implementation of public health programs. Among other positions, he has been the director of disease control for 4 years before becoming the director of maternal and child health at the Ministry of Health and Public Hygiene of Senegal. He is responsible there for coordinating the development and implementation of reproductive health policy. Welcome, Dr. Doucouré. I would like to call out that we are having Dr. Doucouré join. English is probably his 5th language, so we may call on a friend at moments if need be to help with translation in the room. I would next like to call up Ogechi Onohua. Ogechi is the program director at MSI Nigeria, where she leads the design, development, and implementation of programs that enable access to sexual and reproductive health across Nigeria's 36 states and Abuja. And she supports the national and state governments in enabling policy change, service delivery, health system strengthening, and sustainable demand and norm change. Ogechi leads on new business development and fundraising, and she also coordinates strategy for MSI. Before MSI, Ogechi worked for the Society for Family Health, where she led the implementation of maternal health, child survival, and nutrition interventions. She's also worked with Africa Health, Human and Social Development, and at Journalists Against AIDS in Nigeria. She received her undergraduate degree in mass communications and has a master's degree in public health. Welcome, Ogechi. And then lastly, we have Dr. Samson Gebrahmadine. Unfortunately, he was not able to join us today. And so we have some of his responses to the questions we prepared that we will play via video. Dr. Samson is the principal investigator of the Pathways for Ethiopia research project, which is implemented by Project Hope. He serves as an associate professor at the School of Public Health at Addis Ababa University. He has over 20 years of experience in academia and public health research. His work focuses on maternal and child health and nutrition, areas in which he has published extensively. He's received research grants from several prestigious institutions, including the Gates Foundation, IDRC Canada, and the DAD, and I'm remiss, I'm forgetting the DAD stands for, but it is the German Academic Research Organization. So I have several questions to get us started off today. At the same time, we have Slido available. So you can capture Slido through the QR code. And please feel free to add questions that you would like to ask of the panelists. And we will get to those after an initial round of questions and discussion. Just going to make sure everybody's got their... Okay, I think we can go to the next slide. Yes. Great. Okay, so we're going to start with Senegal, and I'll just give you a brief recap of the work that we've been doing in Senegal. I'm actually going to sit down. So in Senegal, Pathways supports the ministry's Division of Maternal and Child Health in their efforts to increase demand and sustained use of family planning, taking into account women's differentiated values, needs, desires, and choices. Dr. Doucouré, what I'd like to invite you to do this morning is to tell the audience in your own terms, what does pathways mean to you?
Good morning, everybody. It is a great pleasure to me to participate at this panel. For me, pathways is a segmentation approach who categorize women of age of reproduction in our country according the vulnerability. The vulnerability is assisted by many factors like health, like economics, like geographic. And a segment represents a group of women who are the same for all items like vulnerability. And in our country, in Senegal, each segment represents a group of women who are similar of term of vulnerability. And in Senegal, we have 8 segments. 8 segments, 4 rural segment and 4 urban segment. And we have 14 regions, and in each region we have segments. And in the region we have several segments who have various proportion. And with the segmentation, we can say that the region is most vulnerable than other region.
Lovely. So essentially how Pathways helps you categorize women into different groups and then see how those groups are differently spread out across the 14 regions of the country.
Yes.
Next, we're going to talk a little bit about Nigeria, or introduce you to the work there. Pathways in Nigeria supports MSI in their family planning demand generation efforts. One of the ways they do that is co-designing job aids for providers to identify segments of women and understand how to adapt demand generation efforts to segment-specific needs and desires. So I'd like to ask you the same question, Ogechi. In your words, what does Pathways mean to you?
Thank you, Tracy, and good morning, everyone. I work in Nigeria, and I work in Kano, Kaduna, and I see Hassana and Bilkis. So Pathway helped me to see the stories and the individual behind those stories, understand what motivates them, understand their true challenges even before I design the intervention for them. That way, I'm able to target my response to their needs and not just treat them as if they are all the same. The reality is they are not.
I love that. Pathways helps you uncover the stories behind the data, blending empathy and evidence. That's lovely. And then lastly, for a brief introduction on Ethiopia, Pathways supports Project Hope and the Ethiopia Public Health Institute in understanding the multidimensional vulnerabilities to reproductive, maternal, child health, and nutrition outcomes in women and adolescent girls as an effort in designing holistic, tailored interventions that span women and girls' health as well as her well-being. And I will say that Ethiopia is one of the first countries where we've added an adolescent segmentation. And so now we'll hear briefly from Dr. Sampson what, in his words, he sees Pathways as.
Thank you, Tracy, for having me in this panel discussion. So to me, Pathways is an innovative evidence-based precision public health tool which leverages women-centered design and which enables frontline health workers to provide tailored public health intervention. So when I say precision public health pathways serves as a basis for delivering tailored interventions in low-income settings, and when I say that is evidence-based public health intervention, it uses data coming from the same settings that we want to serve, not the data coming from elsewhere to develop the segmentation solution. As I have already said, I also consider pathways as an innovative tool because unlike other public health tools which do kind of segmentation based on one or two or fragmented risk factors, in pathways we do segmentation based on a kind of multiple or compounded source of vulnerabilities, including those vulnerabilities which are occurring across the life course. Plus, pathways is also a tool which enables frontline health workers, because in low-income countries, frontline health workers, like health extension workers in Ethiopia, they don't have tools to provide tailored public health interventions. But pathways enables these frontline health workers to deliver the right public health intervention to the right population, at the right time. So in general, I would say pathways is a method, a public health tool, a precision public health tool with the potential to reduce health inequity and also improve health intervention and effectiveness and cost effectiveness of public health interventions.
So one of the things I love when Dr. Sampson talks about pathways is how he borrows from precision medicine and talks about pathways as providing precision global health. Perhaps one of the things that is important to call out in all three of how our panelists have talked about pathways, what we see in Senegal is the Ministry of Health really using pathways to drive data-based and evidence-based decision-making. We'll hear even more from Ogechi about the role that Pathways has played in helping providers do more to reach the women that they need to reach. And Dr. Sampson refers to Pathways as a tool that can actually exist in the hands of frontline health workers. So that is one thing to note, is sort of the diversity of the way to use this data and how it can be used by multiple audiences. We're going to go back to Senegal and do a bit of a deeper dive into this work in Senegal. So Dr. Doucouré, the Department of Maternal and Child Health in your ministry has engaged with Pathways, and you and your team actually developed your own segmentation. You took charge of the process and used the DHS data to develop your segmentation solution. I know that your team is now working with regional teams to apply Pathways data so that those localized teams can create annual family planning operating plans within their districts. I wonder if you could tell us a little bit more about how the application of Pathways data has led you to start from a different set of strategic questions or a different set of decisions that you wanted to make.
Thank you. In our country, we identify family planning as a strategy to reduce mortality, maternal and neonatal. And the modern prevalence contraceptive rate in our country has improved between 2050 and 2023, and increasing 21% in 2015 to 26 in 2023. But we consider that since 2017, the modern contraceptive prevalence rate is stagnant. And we have a target to reach in 2028 a modern prevalence contact rate of 46. If we want to reach this target, we want to accelerate our intervention with all impact, but we must to create innovation in our strategy. And we, with the team project and a team of my director of Mother and Child Health, we involved in developing a national vulnerability-based segmentation of pathways. And because they are priority region in health financing and maternal and child health to region. They are primary regions that contain a high proportion of women belonging to the most vulnerable segment of the 8 segments created in Senegal, the most rural vulnerable. Pathways will help us pathways help in more targeted annual planning by helping regional and district health team understand the segmentation composition in the area of responsibility. With pathways, we understand the social, cultural, and environmental vulnerabilities of the segment in the region of health district, and pathways help to plan the best, most effective and targeted activities to improve family planning indicator and also improving uptake in a region or a health district.
And I have had the great pleasure of being able to work with your team and at the regional level and watch these regional heads really dig into who are the segments that are in their regions and how do they then want to adapt the services to reach the segments of different levels of vulnerability. That's been super exciting. It also, what you're talking about also makes me think about the question of scale. We all know global health, that's a constant question. How do we scale it? And so I wonder if you could talk a little bit how Pathways has led you to think differently about that process of scaling.
Yes, Pathway is an excellent forecasting tool. It'll help us estimate the appropriate segment or geographic area for implementing a large-scale intervention or the adaptation needed to scale an intervention from one geographic area or another. For example, if we test intervention in a city like Dakar, our capital, where successful segmentation help us understand which other regions have a similar segment composition to Dakar, with similar needs and barriers, when scaling up have the greatest impact. Similarly, segmentation also helps us in understanding why a solution pilot in one region might not work in another due to the presence of different segments in that other region, and what adaptation might be needed to make it work. For example, a solution implemented from facility-based contact point in Dakar or Thiès with a big town might be more effective for a community touch point in another region like Tambacounda or Matam with a rural region because of less frequent facilities engagement of segment in this region. Furthermore, the appropriation of the strategies implemented by health actors is decisive for the success of scaling up, whatever the context.
Yeah, I love that. So you know where you can scale because you're going to find the same segments versus where you need to adapt to a new group. of segments. Let's go a little bit deeper into Nigeria. Ogechi, you've been applying pathways, as you said, across multiple audiences in Kano State, including facilities and providers. And I know that you have co-developed a point-of-care tool to help providers identify family planning user types during counseling. I wonder if you could talk a little bit more about how the segmentation data informs a different type of provider-client experience.
So working with the Pathways data and the Pathways team, we've been able to develop job aids that is helping us both in terms of demand generation in communities as well as in the facility to more and better target clients. One challenge we have encountered in terms of in the communities is knowing who to speak what message to. And then in the facility, one provider is doing multiple things. I'm sure, but for those of us who work in Africa, you see one provider, she's doing a whole lot of things. So time is what she does not have. And how can she better do the counseling and still meet the need of that client sitting in front of her? So what we have done is we have a typing tool. The typing tool is for the community in terms of helping demand generation officers be more targeted and know who they are engaging and speak the language that better resonates with that client. Then in the facility, we have what we call a listening tool. So what this listening tool is just a two-faced card. Now, all of these four profiles have been simplified in that card that is in front of the provider. And she just asks check-in questions. By asking the first check-in question, she's allowing the client to talk. And that client is speaking. She's hearing the story of the client. And all of the vulnerabilities that we listened to when we had Hassana recounting her stories, she's able to hear. Hassana has no education. Hassana is dependent on the permission from her husband before she can access healthcare. So what that means is in her conversation in the client counseling room, she needs to speak the language that is resonating with Hassana around permission, obtaining permission, and also around Hassana is someone who is saying God gives children. So she wants to have the number of children that God has given her. So in that conversation, she needs to target that concern that Hassana has around God, have all the children that God has given you. So this enables that provider to conclude the counseling session and be able to convince a Hassana to willingly take up a contraceptive method, as against having a conversation and the Hassana just walks up because she's not convinced and she cannot make a choice. Also in the community, our demand generation agents are able to use the typing tool. Now in this typing tool, we are able to see from the conversation we have listened to, we have the urban and we have the rural. Now, when the agents are working in a rural community, again, these four profiles are available in both the rural and also in the urban. So when they are working in a rural community and they are having that conversation, they are speaking to a Hassana by, again, asking the same questions, and that allows Hassana to tell her or him her story. And by hearing that story, she's able to know that, oh, I need to target Hassana's husband. So that informs our conversation around male involvement. I need to target religious leaders. So that informs a design of messaging that engages religious leaders, so that Hassana in the home, through the religious leaders, her husband is exposed to conversation on contraceptives that is supportive of her religion and understands that Islam or Christianity is not against contraception. So he goes home and then is able to reinforce that same conversation with Hassana. And when Hassana makes the move from the home to the facility, and the provider is also having a counseling conversation that is aligned with this same messaging, then Hassana is able to leave that facility with a contraceptive method of her choice. And this is how we are able to use the Pathways insights and be able to target the different profiles and read them in our counseling rooms or in our communities.
That's great, and I feel like you've taken something Dr. Sampson said. It's about delivering the right message to the right person in the right way and at the right time. For those in the audience, Ogechi has mentioned something called the typing tool. The typing tool is it's a cheat sheet for segmentation. We're not going to go into it now, right in this session. Melanie, at the end of the session, will share links to a lot of the resources of Pathways. And so if you're wondering, what is this typing tool? Please go to those resources where you will learn a lot more. So thank you. All right, let's go a little bit deeper into Ethiopia. Ethiopia is actually right now, Dr. Simpson is leading the process to create a women of reproductive age segmentation solution and an adolescent and young women solution. And so we're going to hear a little bit from him about adapting the Pathways survey to make it specific to the Ethiopia context. That's something we do when we go into every country. We really contextualize it for that geography, the needs of that location, and how they expanded the methodology into creating a separate adolescent segmentation solution. So over to Dr. Sampson.
Yeah, thank you, Dr. Tracy, again. Project Hope, an international humanitarian organization based in US and also having presence in Ethiopia, is developing population segmentation solution, actually two population segmentation solutions, one for women of reproductive age and the other one for adolescent girls. And currently, we are implementing national surveys in these two specific populations. So in the process of developing these population solutions, we are directly adopting the Pathways methods, but in terms of yeah, thank you, Dr. Tracy, again. Project Hope, an international humanitarian organization based in US and also having presence in Ethiopia, is developing population segmentation solution, actually two. Yeah, thank you, Dr. Tracy, again. Project Hope, an international humanitarian organization based in US and also having presence in Ethiopia, is developing population segmentation solution, actually two population segmentation solutions, one for women of reproductive age and the other one for adolescent girls. And currently, we are implementing national surveys in these two specific populations. So in the process of developing these population solutions, we are directly adopting the Pathways methods, but in terms of the qualitative tools and also the survey tools, we are adapting the existing tools developed by the Institute of Disease Modeling and its partners. So we are kind of customizing these tools to the Ethiopian settings. And as you have already said, we are extending these methods and tools to the adolescent girls. So in terms of adapting the tools, specifically in the context of women of reproductive age, and also extending the methods and tools to adolescent girls, the process had been led through a national qualitative study. So this national qualitative study had been used, one, in terms of defining source of vulnerabilities in the context of Ethiopia, and the other one is in terms of defining key outcomes specifically for the adolescents population segments, and the third one is fine-tuning some methodological aspects that I will be discussing later on. So in terms of source of or customizing the potential source of vulnerabilities, what we found in qualitative studies, the 6 domains, vulnerability domains of the Pathways project, they are quite comprehensive and also representative in the context of Ethiopia, both in the case of women of reproductive age and adolescent girls. But within those specific 6 domains, specific source of vulnerabilities, context-specific source of vulnerabilities had been identified and added. Beyond that, in terms of outcomes, so as you have probably mentioned in the earlier session, pathways had been primarily focused in previous undertakings on reproductive, maternal, newborn, child health, and nutrition outcomes. But in the case of adolescent girls, the major cause of mortality and morbidity are beyond this RM and CHN outcomes and including injuries, substance use, common mental health disorders, gender-based violence, and the like. So we have used this qualitative study, the national qualitative study, to identify the proper or the most relevant epidemiologically in terms of mortality and morbidity, the most relevant outcomes for the population segmentation for the adolescent girls. Third, in the context of methodology, the qualitative study had been used to customize or to fine-tune some methodological issues like which age range should be appropriate for the adolescent population segmentation, and plus which should be the appropriate eligibility criteria so that we won't introduce selection bias in the study. So in general, the take-off message that I have regarding the points that you raised is while we extend pathways to new geographies or while we apply pathways to specific population segments like adolescent girls, this process should be informed by context-specific qualitative studies as we did in Ethiopia.
So of course, as an anthropologist, his emphasis on the need for that qualitative work to not just inform how we understand vulnerability from a woman's perspective, but also how we begin to even think about what are the outcomes that we really need to be addressing and that are produced by these vulnerabilities. We're going to stay on Ethiopia for the next question. Pathways is a fairly new methodology within global health, and it pushes us to start our work from a different mindset. It hasn't always been easy. There have been challenges. We are honest about that. And Dr. Sampson is going to share one such challenge and how they overcame it in Ethiopia.
Thank you, Dr. Tracy. So the major challenge that we faced in the pathways process was the need for narrowing the scope of our qualitative and quantitative studies, because in pathways we do horizontal segmentation and we need to collect data on multiple RM and CHN, even beyond, and other outcomes beyond RM and CHN. And plus, in terms of vulnerability, we have the 6 domains. Within those 6 domains, we have multiple source of vulnerability. So, for example, in the case of Ethiopia, we had a very comprehensive systematic review. We conducted national level qualitative study. We also conducted secondary analysis of data. And at the end of the day, we had a long list of potential sources of vulnerabilities that should be measured in our qualitative study, in our survey. But in reality, translating those long and ambitious list of variables into meaningful and feasible survey proved challenging. So we have to do prioritization of these variables. So stakeholder engagement meeting, and also through ranking of the variables based on the qualitative studies that we already completed. And plus, we have also learned from the other pathway, national pathways, and other pathways projects that we led in other settings. In addition to that, we also conducted cognitive testing of the survey tools. So in the cognitive testing, beyond understanding of how best the questions and the questionnaire should be administered, that exercise has also enabled us to identify which questions are less relevant or have low discriminatory power in the Ethiopian context. So through this diverse approach, like stakeholder engagement, learning from other pathways project, and also cognitive testing, and also plus the qualitative studies that we conducted, we have somehow managed to create balance between comprehensiveness and methodological rigor. Thank you.
And I know I've seen some of the questions coming in, so it's possible that some of Dr. Sampson's his response there got to some of the questions about survey development and so on. I'm going to jump back to you, Dr. Doucouré. Could you share with us what Pathways has taught you that you might not have known before?
Thank you again, Tracy. Pathways has taught us that we can more efficient in our intervention. Especially in this context, we observe a reduction financial would allocate of health. And during the 2 last years in our country, we conduct several SDGs because we want to base our politics to data, to evidence. And we have several SDGs like we have the analysis of the causing of discontinuity of family planning. We have the analyzing the bottlenecks who contribute to not the scale up intervention with impact. And we think that if we pull the recommendation of all SDGs and the pathway tools, we can improve our national budgeted family planning for the 5 next years, and to contribute to reach our target of 48% in 2028, and to reduce at 10% the inmate of planning familial.
Great. So to really reach those targets more efficiently. Ogechi, I'm going to turn to you as well in terms of what is something that you would want the audience to leave with knowing about Pathways?
Pathways, I would like the audience to know that Pathways enables you as it will enable you as it is enabling me to understand the vulnerabilities of the clients that I serve, to understand that the support system that a Hassana requires or a Bilkis requires is not the same. The information that they require is also not the same. So having that understanding enables targeted programming. And in essence, what this is helping us is to take responsibility to address the inequities that is impacting client access to care. I work in a country where our MCPR is 15%, and we have a population of over 230 million. If I'm going to be working and contributing to increasing that MCPR to 27%, then I need to address these different inequities and be able to reach the clients and get more clients to accept services. And Pathways is enabling that for the programming that I'm doing in Nigeria.
Love that. So addressing inequity by moving away from one-size-fits-all interventions. So we've got some great questions from the audience. I'm going to start with you, Dr. Doucouré. The question from the audience is, how was Pathways co-created with health experts in Senegal?
Je peux vous aider un peu avec la traduction. Je crois que c'était clair.
J'ai compris, oui, oui.
Vous avez compris?
Tout à fait.
OK.
Je peux parler en français?
Oui.
OK, donc pour Pathways, au Sénégal, nous avons mis en place un groupe technique de travail constitué par une équipe de la direction de la santé de la mère et de l'enfant. Et aussi,
Okay, so in Senegal, they put together a strategic team in the Department of Maternal and Child Health.
et l'équipe du projet.
So a project team to work on Pathways.
Maintenant, nous avons tenu une série d'activités qui a consisté à faire une analyse situationnelle, à faire des enquêtes de terrain, mais aussi analyser les résultats.
Okay, so it was Senegalese experts who really developed the approach that they were going to use in Senegal and developed the approach to collect information at the level of different communities.
Et à chaque étape du processus, on fait des analyses.
So that at every step of the process, they analyze what's happening.
Jusqu'à ressortir les résultats finaux.
Just to the point where they have the final results. So they don't wait till the end, they analyze step by step.
Et après, nous avons partagé avec l'ensemble des parties prenantes lors d'une séance de restitution.
And then they had a workshop, like a dissemination workshop of all the results to share with all of the stakeholders involved in implementing some of these programs and projects.
Et maintenant, nous sommes à la phase d'opérationnalisation au niveau de 2 régions. que
Okay,
l'on
so now
considère-
they're just starting to roll out the Pathways approach in 2 regions.
que l'on considère comme des régions prioritaires.
So the regions that the Pathways help them identify as priority regions.
Donc, toutes les activités ont été faites en commun.
Yeah, so everything was done, was a co-creation process. And all of the Senegalese experts were involved at every step of the process.
Merci. And just to note that all of the methodologies that we have used in Pathways are available. They are open source on the website. And we have, with our colleagues at the Gates Foundation, the Institute of Disease Modeling, we have created software for segmentation solution development for countries to lead that process on their own. And in many ways, working with Senegal helped us understand what kinds of support a country needs to do that. And so we learned as much from Dr. Doucouré and his team as maybe they did from the Pathways process. So thank you as well. Ogechi, how does Pathways data compare to other data that you've been using in the past with MSI, with the Kano state government, and so on?
The difference between the Pathways data and the other data sources that we've seen or we have had access to in the past is the insights and the profile segmentation that the Pathways data gave to us. The Pathways data gave us insights into different profiles of the clients that we need to meet. And that, for me, is the difference. So based on that insight, we are able to... So the Pathways data, the difference between it and the other data sources available to us is around the segmentation, using the vulnerabilities and the other indices or experiences of the individual to profile them and to help us understand what is the means of communication to reach this person. It was quite clear. How do you have conversations with this individual? So that analysis and that segmentation made it very easy for us. And then the support also we got from the team in terms of translating these insights into designing tools that can enable the provider who is in a counseling room with a client through a cheat code to save time and jump from having to go through multiple conversations to just straight to the point, oh, I am in the front, I am with a client that is a Hassana, or I am with a client that is a Bilkis, and then go straight to what she needs to hear. Same thing also in the community. This, for me, is the difference between the Pathways data and the other data sources.
Thank you. Maybe I will, we did have a question from the audience around, can Pathways data be used with existing data? And that might build on your question well. Yes, it can. And there's a number of different ways. We mentioned the typing tool, which is the most parsimonious set of questions. It's roughly 10 questions, not sensitive questions, not difficult for a woman to answer. You can include those 10 questions in any survey, in any recruiting structure, and then all of the data that you get back, you can look at through the lens of vulnerability. So it's very easy to map from the Pathways data to other large data sets. A second way that we have 2 ways of developing segmentations. One is through the Pathways survey, and one is using existing large data sets such as DHS. We use the DHS in Senegal. And so it automatically maps to DHS, which is obviously one of the data sets we use so commonly. So pathways can be applied and integrated with existing data. Okay, we have a sort of nuts and bolts question, and I think I'm going to phone a friend, Lee Pine-Mercier, who is with Sonder Collective and has been working very closely with Dr. Sampson and his team on developing our version 2.0 of the Pathways Survey. The question is, Lee, how long is the segmentation survey? Roughly how many questions? Maybe, yeah.
Thank you very much. After the survey was first fielded in India, Nigeria, and in Kenya, we decided it was time to revise it, and based on the lessons from that round, for using it in Ethiopia. It's a little tricky to say the number of questions because there are skip patterns, but what we have, there are multiple modules. There's a male module, a household module, and a woman's module, and the time period to conduct those interviews is 90 minutes. And I think the survey is very interesting and unique compared to existing instruments people may know, like the DHS, because not only does it have health outcomes, current health status, and health behaviors, it also has many questions about the social, cultural, household life of women, also childhood adversity experiences that allow people to analyze all of these experiences and how they affect women's lives today. So it is a household survey. It takes about 90 minutes. Thank you.
Thank you. We also have another question from the audience. How does Pathways scale to other health outcomes, such as malaria, HIV, and mental health, were the three examples we were provided? This is a really interesting question. When we started Pathways, we were very focused, as we've said, on reproductive, maternal, child health, and nutrition outcomes. Very early on, though, we did get a question as to whether Pathways could be applied to zero dose, for example, in the immunization space. And we tested it, and in fact, it did apply to zero dose. So segmentation membership in northern Nigeria is slightly over 80% predictive of whether a woman will have a home birth, as Melanie talked about. We have the same level of predictability for whether a family will be a zero-dose family. That makes sense because we now know that immunization behaviors are very related to a woman's own health-seeking behaviors. So we have started to also experiment with applying Pathways to other outcomes. Mental health, yes, it applies there as well. We collect, as Lee talked about, we collect a lot about social support and feelings of belonging in a community, which speak to a woman's mental health. HIV, not so much. The vulnerabilities that make someone vulnerable to contracting HIV are different than many of the vulnerabilities that pertain to sort of health seeking around reproductive and maternal care. Or there's enough difference that we don't feel you can use Pathways for HIV. So all to say, it's still something we're experimenting with, and we're always doing experiments on Pathways. So if you have additional outcomes you'd like us to try it against, we're more than happy to do so. Okay, I have a question that is both for Dr. Doucouré and Ogechi. Maybe Dr. Doucouré first. What is the timeline for a Pathways project?
Vous avez suivi la question? Ça a pris combien de temps et quelles sont les phases d'exécution de l'approche Pathways?
Actuellement, je pense que nous sommes à 17 mois de mise en œuvre.
Comment?
18 mois de mise en œuvre.
2029.
Oui,
OK.
de mise en œuvre de ce projet.
OK.
Avec différentes phases qui ont consisté à une revue documentaire
OK.
et d'enquête sur le terrain.
Donc, combien de temps en tout, vous avez dit? J'ai pas entendu.
18 mois.
The micro, s'il vous plaît.
18 mois, nous sommes à 18
Oh,
mois.
okay. So a year and a half in total from starting to develop and refine and adapt the questionnaires to having the
travers-
data to analyze and selecting the 2 priority
Il y
regions.
a différentes étapes qui ont conduit vraiment ce processus. Il y a une phase de revue documentaire, une analyse quantitative,
Yeah, so
analyse
started with
qualitative.
reviewing documents, doing a quantitative analysis as well as a qualitative analysis.
Enquête qualitative avec des enquêtes sur le terrain,
Yeah.
rédaction des rapports.
And then actually analyzing first, then doing the surveys, and then coming back and analyzing again what was collected.
Voilà. C'est ça.
Great, thank you. So in a geography where we are starting out creating an entirely new segmentation, as we did in Senegal, it takes about a year and a half. Ogechi, we came to you with an already prepared solution. So maybe you could comment a little bit on how maybe the slightly different timeline for the work in northern Nigeria.
So in northern Nigeria is a bit different. The data sets were actually already available, and then the different profiles were already available. So all it took for us was to have conversations with our providers, and they began to run. They began to run with that implementation. However, to come up with a typing tool, the job aid, has taken us a bit of a time, and I would say less than 6 months, because we had to do a co-creation workshop where we had to bring providers as well as community-based mobilizers into the room to understand what will work for them and for them to help design that job aid. That same job aid was taken back to do a piloting of it to see what kind of, is it having the same effect or the same result that we intended for it to have? And that is taking us a bit less than 6 months to be able to do that. But in terms of the conversation, the providers were able to run with it. But that cheat tool to shorten the time is what has taken us this length of time to do.
Great, thank you. Thank you all for these additional questions. I'm going to turn it back over to Melanie. Yes. And so that we can show you some of the resources that are available out in the world for you all to start using Pathways right away.
Thank you for this excellent panel. Thank you to the panelists. Thank you for Tracy. Next slide. I hope, as we all heard in the last 40 minutes, Pathways, data, and insights, its tools and the process really help us to design more equitably, really understanding who we're reaching, who we're missing out. It helps us also to be more efficient. What can I do beyond my vertical program? How can I connect with other programs that are going on? And in some cases, using the existing data to actually accelerate and get a head start on programming and design. And finally, being more effective is really solving for the right problems. So thank you again for our panelists to kind of showcase the work that you have been doing. Now, you may be asking, and we have already addressed this a little bit before, is this how can I use Pathways? How can I engage with it? All of the Pathways data, can we go to the next slide? Thank you. Pathways is a digital platform in production, but we do already have quite a bit of data up on the website, so you can scan the QR code and kind of dive into the data. There's also tools and processes that are available, and yeah, consultations are always welcome, so just walk up to us after the session if you have any more questions or think about how to use Pathways in your country. To close the sessions, we're a little bit early, but I think no one minds an extra coffee break. To close the session, we're going to have another short video for you to kind of summarize what we've all seen with Pathways. And with that, I already thank you for being here this morning, for listening, and look forward to having interesting discussions with you as you leave after the session. Thank you.
Imagine a world where every woman has access to healthcare that specifically meets her needs. This goal is ambitious, Yet every day we see it is within reach when we use woman-centered data to better understand the unique needs and circumstances of distinct groups within a community. Pathways digital platform helps us see these needs and circumstances more clearly. Quantitative and qualitative data and insights are joined into rich population segment profiles based on social, economic, cultural, and environmental factors. Rigorous modeling tools are used to further deepen understanding of diverse health needs. By revealing factors that shape health behaviors and outcomes, Pathways can help you, from evaluating digital health services to designing inclusive antenatal programs and more. Pathways is supporting policymakers, donors, analysts, and implementing partners in more than 20 projects across 7 countries. Forecast, design, resource, and evaluate holistic health solutions that are more precise, intentional, and impactful. Explore Pathways data and insights. Join our growing community, and together we can ensure that every woman has access to healthcare that specifically meets her needs.
Out of the session, you have a card on your seat. Feel free to leave us some greetings, post on LinkedIn, and come and chat with us. Thank you.